Thank you very much. So the next speaker is Dr. Al-Hafez, emergent cannulation. That can be really a lot of fun, and especially emergent decannulation and navigation through the ECMO complications. Please.
Thank you. Good morning, everyone. I'm Dr. Al-Hafez. I'm an advanced heart failure and transplant fellow in University of Texas. My only disclosure that most of my mentors and role models are in the room, and it's not making me nervous at all. So I'd like to present to you this case, how MCS can be a blessing for our patients and a bailout, but also can be problematic and put us in a tight spot, and how shock can be dynamic, and we have to, it always keeps us on our toes while managing these patients. So our patient, it was an early Saturday morning. He's a 39-year-old man, was at work, and suddenly fell down, passing out. When EMS arrived, he was normotensive, but he was encephalopathic, tachycardic to 150s, hypoxic, oxygen saturation 40 is 50%, so they put him on a non-rebreather mask. When they brought him to the ED, our colleagues downstairs put a point-of-care ultrasound that showed RV strain. While they were assessing him, he vomited, went into PEA arrest. ROS was achieved within 5 minutes. They intubated him, and because of the hypoxia, tachycardia, and clinical suspicion, they decided to give him thrombolytic, tenecteplase, full dose empirically. However, patient lost pulse again CPR, one round of CPR, and he was started on norepinephrine, quickly escalated up to 20, aka jet fuel. Just a quick background, he's fairly healthy, obesity class 1, aka Texas normal, no past surgical history, nothing, no substance abuse. These are his initial vitals, as you can see, afebrile, sinus tachycardia, he's on mechanical support, intubated. This is a glimpse of his labs. As you can see, he's in renal failure, lactic acidosis up to 25, beginning of shock liver with his LFTs up into the hundreds, and some, as you can see, some INRs elevated already. Troponin high. We did not have a BNP or pro-BNP. And that was the call that our team got for the ECMO consult. We have a fairly healthy man, a young man, sudden cardiac arrest. Now he's sliding on pressors, high clinical suspicion for PE. So they posed these questions for us. Should we get CTA? Should we wait for you guys to put on ECMO? Although he just received a full dose of thrombolytic, or do you think he would benefit from catheter-directed or surgical thrombectomy? Luckily, HVI and ED, they're far from each other. By the time we got down there, he already got the CT. As you can see, bilateral emboli, massive PE, flattening of the septum, RV-LV ratio. These are the obstructive PE, as you can see. And there was a small comment at the end of the report. There's a mild amount of perisplenic and perihepatic fluid, which will become important shortly. The decision was made to put the patient on VA ECMO. This was done bedside ED through a FEM approach, 10 minutes after the CT was done. So the CT 650, ECMO is flowing at 7 a.m. Repeat labs showed improvement in his metabolic shock state, at least. Lactate was down to 5. Hemoglobin dropped from 39 to 31. You know, when you first get these labs, maybe he was hemoconcentrated, we're not sure. Patient was weaned off norepinephrine. However, MAP started to store again. Now he's on the ICU. ECMO cannula started to chatter. We challenged him with fluids, 2 units of RBC. Repeat labs show that hemoglobin is still dropping despite multiple transfusion. So now we know he's bleeding somewhere. And we started him on massive transfusion protocol. We hold down the patient with his ventilator, ECMO, everything down to the CT again. We showed that the PE, luckily the burden is coming down. There is decreased RV strain on the CT. However, now we have hemoperitoneum, and with aberrant extravasation in the venous phase in the hepatic subcapsule. All right, now we're at our second decision point. The patient is in cardiogenic shock, had a massive PE. Now that turned to hemorrhagic shock. He already received TPA. He's receiving active anticoagulation. He's on ECMO. Do we continue, stop, or reverse the anticoagulation? Should we continue the ECMO or take it out? Should we replace the ECMO with MCS? Is he going to fly on his own now? Is he ready? Lactate starts to climb again. Abdomen is progressively getting worse. So we decided to reverse the anticoagulation, and he got a bunch of FFP, cryoprecipitate, and he was emergently decannulated within about 12 hours from the cannulation. We talked to IR, vascular surgery. Can we stop the bleeding percutaneously? That was not an option based on the CT. So general surgery took him emergently for XLAP. They evacuated more than 3 liters of blood and identified the subcapsular liver as the source of bleeding. This, as you can see, the hematocrit trend. As you can see, the patient, the next plays CTA chest when the ECMO was flowing. This is one of the massive transfusion. We're trying to slow down this curve. Well, we got the CT. After the reversal, we got some improvement, ECMO out, and then XLAP, and these are the 48 hours that weekend. The patient subsequently needed another 2 XLAPs for washout and packing, completely off anticoagulation, although he just had a massive PE, it's your call. He was extubated eventually on hospital day 4, started in heparin infusion hospital day 5. And organ damage as in the form of AKI and shock liver completely resolved. Heparin increased gradually, and he was discharged on hospital day 12 after only 7 days in ICU to a skilled nursing facility, and he's doing well now. That's all. Thank you.
Very nice. Please question, Dr. Bakri.
Fascinating case. Great management. I think you guys did everything that could ever, be imagined to be done. Truly a, challenging case, probably COVID-related too, in terms of the DVT-PE risk, tenfold higher than compared to the non-COVID cases. So I was actually very intrigued by the immediate, TPA in the ED setting, and then you being able to cannulate within 10 minutes of a CT. That was quite impressive. So I don't have any other further comments than to say kudos.
Yeah, thank you.
Don't you think the key to this case is the PE dissolved just in the nick of time? Mm-hmm. Or you never would have been able to go through that brief...
Those bilateral PEs, to be able to demonstrate, at least hemodynamically, to have been resolved with just a little bit of increased flow after the TPA. That, I think, by itself is quite, by I think, stroke of luck, was beneficial to be able to come off the ECMO.
Definitely, yes.
Ali?
Great case.
Thank you.
I just would like to underline one problem. If this patient now wouldn't be ready to be decannulated from ECMO, that's what we would have done. I think to stop anticoagulation was the right thing, even with keeping him in ECMO. Modern ECMO circuits forgive you a period of time without any anticoagulation, even to go for surgery under ECMO, for abdominal surgery with ECMO. We did that, and the patient tolerated that. And the ECMO machines, if you're using the best hemocompatible ECMO machines, that means not too many connectors and not too many bridges, those kind of ECMO circuits are forgivable for thromboembolic events without any anticoagulation.
Mm-hmm.
Thank you. Any other comments?
Hi, very nicely done. Shubhi Chatterjee from Houston. I have sort of 2 questions. One is, was an IVC filter considered at the time of ECMO decannulation when you still have the ongoing bleeding and that's being taken care of in the setting of a PE? The second is, the Maryland group writes about, and they're probably the leading advocates, of basically putting everyone, or just about everyone with massive PE on ECMO up front, and then sort of waiting it out. And about half the patients get better just on ECMO with heparin alone versus any additional therapy. So I'm curious to know, as you approach it, do you think, how routine should we be doing ECMO for massive PE?
Mm-hmm. Go ahead, Dr. Khan.
You have to realize when we say VA ECMO, of course, this is a shock symposium, we're talking ECMO. ECMO is not without complications. ECMO is a big device, you're putting it, so there has to be very good reason in a risk and benefit analysis that when you want to do an ECMO. Having said that, in a patient who has acute PE and has hemodynamically unstable, then we have a very low threshold in putting an ECMO. But if his hemodynamics are stable, then we try not to put an ECMO. To all comers, we would never put a VA ECMO if there's bilateral PE, even if there's RV strain, because like you saw here, one dose of tenecteplase almost changed the hemodynamics. And that is usually the case if you are able to manage it. But if the patient is hemodynamic unstable, is now hypotensive, or is having other problems, which is, some people come coding and some people do that, then we have a very low threshold putting in VA ECMO.
Bravo to the general surgeons that went in there and stopped that bleeding on the liver, because the temptation is to start playing with plasma and reversing all the heparin and the TPA and all that. And once an abdomen is tense from massive bleeding, all that's just a game. You got to go in there and pack it off. So bravo to them too.
That's an excellent point.
Ali's point of we have continued VA ECMOs in many perioperative settings without removing it and running it without anticoagulation with high flow. In this case, we removed it. He was a young guy, number one. He was hypercoagulable because of the COVID, which Beacom said already. And number three, we were actively giving him procoagulants and pumping his circulation with FFPs and cryoprecipitates and factor 7 and everything else. So we didn't want to take a chance with such a young guy. That's why we took it out.
And I was going to mention IVC filters probably is not going to work, because the in situ pulmonary clot formation is the sort of a mechanism by which COVID-related PEs happen. So it's not necessarily from the deep veins. So you could have clots anywhere in the vasculature.
And we did venous Dopplers, and he did not have DVTs in the leg, so we chose not to get, because in itself, as you know, IVC filters are procoagulant, prothrombotic.
Right.
And in all the papers that have come out, only first 13 days there is any mortality benefit. Otherwise, it actually increases mortality.
Thank you. We have one more quick question over there.
Thanks. Excellent presentation. I loved it. Faraz Masood from WashU in St. Louis. Do you guys have a PERT team? Was this discussed on a PERT team, or was this individual phone calls? And whatever the answer is, yes or no, I would like to know, the panelists, that if you all have a PERT team in your institutes or not.
I can take that one.
Yeah.
So we started doing massive PE supported by VA ECMO at Herman probably 2012, 2013. And at that point, multidisciplinary teams decisions were being made with multiple team members. And then of course PERT came a little while after. And I keep going back to Dr. Googlin's paper about that VA ECMO being a bridge. And I think we were doing that bridge. And so we will officially join the PERT team as far as the registry, but I think that multidisciplinary call, Faraz, that you mentioned about, that's the soul of VA ECMO as a bridge, regardless of the etiology, because you have multiple stakeholders. So we call a conference call, everyone is on, and we're trying to now engage our nursing colleagues. And if in the future, if an ethicist is willing to be on call for 24/7, we'll invite them as well. So then the decision is made based on the hemodynamics. And CV surgeons are crucial to that, because we have taken these patients, bridge, take them to the OR, or it's a bridge for the TPA, which I don't think we would have even considered 5 years ago. But we have now seen that before it was like with the TPA, can we still go on ECMO, retroperitoneal bleeds and all of that, which clearly did happen, but this was a young guy. And to the comment about the Maryland group, I will challenge them. When you have 16 ECMOs with COVID, I don't think we have the luxury of trying out until we have an RCT, which probably will not have for a long time. But VA ECMO and intracranial hemorrhage is a pretty big deal. So we should really do it in a select few patients, especially as it considers with massive PE and COVID too.
No, thank you. Thanks for mentioning that. My point about PE was, just like you said, a multidisciplinary, institutional-based call.
Absolutely.
So that's great. Thank you.
Thank you.